much, Naveed. Can I be heard?
Yeah.
Okay, thank you very much. So I now invite Petr Ostadal for his talk, VA-ECMO and Cardiogenic Shock, Clear Evidence of Benefit, and I will show you. There he is.
Thank you very much. Good morning, ladies and gentlemen. First of all, I would like to express my thanks to the organizers for inviting me. It's my pleasure and honor to be here with you. And now I have a very, very difficult task, show you the clear evidence of benefit for ECMO in cardiogenic shock. My disclosures. Here we have the overview of the recent randomized clinical trials on ECMO in cardiogenic shock. You can see no difference in 30-day mortality, including our ECMO CS trial. Does it mean that there is no benefit from ECMO in cardiogenic shock? I think that these trials had important limitations, and I will just say a couple of them. First, this is the definition of cardiogenic shock. We all know there are many very similar definitions of cardiogenic shock. Here we have one of them. Cardiogenic shock is a syndrome due to primary cardiac dysfunction resulting in a low cardiac output with tissue hypoperfusion. We have also clinical criteria for the clinical diagnosis of cardiogenic shock, and these criteria are frequently used also as an inclusion criteria in the randomized trials. The first of them is the presence of hypotension, and the second are some signs of hypoperfusion. Hypotension here is a surrogate for low cardiac output. I understand that was necessary in the past where we were unable to quickly measure cardiac output. However, the situation has changed, and currently using ultrasound or pulse wave analysis, we can assess cardiac output at the first contact with the patient with suspected cardiogenic shock. So I don't think we need more hypotension as this criterion. Moreover, ventricular filling is frequently not assessed, assuming that, especially in patients with acute myocardial infarction, it must be higher. But it is not necessarily true. Similarly, as hypotension doesn't mean low cardiac output. So if we consider these clinical criteria, I don't think they meet the definition of cardiogenic shock. And I am very happy for this, I think, big step forward in the American guidelines for heart failure, where are these suggested shock hemodynamic criteria that include low cardiac output and high left ventricle filling pressure for the diagnosis of cardiogenic shock. Another major problem in the recent clinical trials was the inclusion of cardiac arrest survivors. And the proportion of these patients were very high. As you can see in the ECRS Shock 1 trial, 95% of patients were after cardiac arrest. In the EuroShock trial, 49%. And in the largest ECRS Shock 2 trial, 78% of patients were after cardiac arrest. We all know that the cause of cardiogenic shock is cardiac pump failure. However, the cause of shock after cardiac arrest is the whole body ischemia during cardiac arrest, plus minus cardiac pump failure. The whole body ischemia already implies that there must be a significant peripheral component of the shock, and therefore it is frequently the situation after cardiac arrest called a sepsis-like syndrome with completely different guideline recommendation for hemodynamic stabilization than for cardiogenic shock. Here we have a very nice study from Denmark. This is a retrospective study using the same inclusion criteria as was used in the recent randomized trials in acute myocardial infarction cardiogenic shock patients. Here we have in blue patients after cardiac arrest and in red patients without cardiac arrest. And if we look on the graph on the left side, there is a cardiac output. And we can see that it is restoring much faster in patients after cardiac arrest. And if we look at the really beginning, that is a cardiac output at the admission to ICU, you can see that it is around 4.5 liters per minute. Therefore, at least significant proportion of patients, including in these trials for cardiogenic shock in acute myocardial infarction, have absolutely normal cardiac output. And if we look at the graph on the right side, there is a SVO2, and we can see that patients without cardiac arrest in red, they have, let's say, borderline normal SVO2, but the SVO2 in cardiac arrest survivors in blue is completely within the normal limits and maybe even higher. Normal or higher SVO2 almost preclude the presence of true cardiogenic shock. So did the subjects in recent randomized clinical trials really have cardiogenic shock? I am not sure about that. And I would like to finish with this analysis from our ECMO CS trial. This is the subgroup analysis of the interaction between treatment strategy and one-year mortality. It is a post-hoc subgroup analysis of the small trial, therefore definitely inconclusive. However, if we look at the subgroups, there was no interaction in the subgroups by age, sex, presence of ST elevation, myocardial infarction, performed PCI, baseline ejection fraction, baseline lactate, or baseline vasoactive inotropic score. However, we found significant interaction between treatment strategy and one-year mortality in subgroups by mean arterial pressure. As you can see here, patients with mean arterial pressure at baseline 60 millimeters of mercury or less probably had benefit from immediate ECMO. And similarly, we found significant interaction between treatment strategy and one-year mortality in subgroups according to the shock index. Again, patients with a shock index above 1.3 probably benefit from immediate ECMO. Ladies and gentlemen, allow me to conclude. There is currently no evidence for the routine use of ECMO in patients with acute myocardial infarction and hypotension. However, a large proportion of patients enrolled in recent clinical trials probably did not have cardiogenic shock at all. From immediate insertion of ECMO might benefit patients with persistent severe hypotension despite intensive conservative therapy with inotropes and vasopressors. And the evidence of ECMO in true cardiogenic shock with a low cardiac output is unfortunately still lacking. Thank you for your attention.